Afternoon. Uh, Welcome to the presentation by Orthopedic Department. Uh, all the patients that we operate, a very large number of these patients have medical comorbidity, and we seek help from our physician colleagues to manage these medical comorbidities before they are subject to anesthesia and surgery. And more than 95% of these cases need medical treatment by some drugs or interventions before they are operated. Now we present an interesting case, patient who had multiple medical problems, and we took opinions and help from our physician colleagues in various departments. Some of the problems continued in the post-operative period, and when the patient was investigated, we find a very rare cause for his medical problems. For his medical problems, another surgery was required to cure that medical problem, and he had a wonderful outcome. So I invite Dr. Pulak for his presentation.
Good afternoon, everyone. A great presentation by the Department of Psychiatry. So we have a different case, and I feel it is less orthopedics and a lot of endocrinology and pathology for this case. So this is a case of hypercalcemia which came to us, and then how we led to the discovery of the cause of hypercalcemia is what we'll discuss in this case. So this is a 53-year-old male who fell from a scooter due to dizziness. He did not have a traffic accident. He did not have any event that happened. He felt due to dizziness and was taken to a hospital outside AIIMS where he was diagnosed with subdural hematoma and was operated for that. No other significant injuries were diagnosed at this time, and he was discharged from the hospital. A few days later, he felt pain and had difficulty in moving his right shoulder when a right proximal humerus fracture was diagnosed. A shoulder immobilizer was given to this patient, but 3 months later, the fracture was not healing, and he finally presented to our OPD. So there are few things that are very specific about this proximal humerus fracture and why he had to come to a tertiary care hospital for this. So this in this fracture, one thing that we can clearly see is the difference in the dimension of the two parts of the humerus, the shaft and the humeral head. This is primarily because this was a circle which got resorbed due to the time period. So we now are facing a shell of bone, which was initially a circle of bone. So this is a one major problem. The second major problem is the medial collapse of the humeral head, which we call varus collapse. So varus collapse is a very biomechanically disadvantageous position. It does not allow healing. It does not allow good range of motion. So it's a very problematic kind of a position, this medial collapse of the head. The third problem in this fracture was that fractures like these are very highly prone to avascular necrosis of the head of humerus, which can eventually make management even more difficult for us. So probably that is why the patient came to a tertiary care center where we decided to manage his non-union. So the personal history of the patient was a little interesting. He was a known case of gluten enteropathy. He was hypertensive on medications. He had hypercalcemia post the subdural hematoma surgery, for which he was being managed conservatively with calcitonin spray. The cause of this hypercalcemia was unknown at present. He also had mild renal failure, for which no present medications were being taken by him. So this is the calcium profile of the patient when he came to us for the first time. Calcium was high normal, phosphorus was normal, vitamin D3 was reduced, IPTH was normal, and ALP was very high. This profile did not look very shocking to us, knowing that he is in hypercalcemic on calcitonin. The only part that was a little off was the normal value of the IPTH. The patient was sent to the respective departments for clearance for surgery, and he was almost cleared by all departments. But endocrinology cleared the patient only because his hypercalcemia was controlled at present. He was told to follow up in the endocrinology department after the surgery to work up for hypercalcemia, as the cause was still unknown. So proximal humerus fractures, these fractures are known for non-union and varus malunion. The management of these cases is done in two ways. One is managing them in a conservative manner, which is mostly kept for elderly people or with stable fractures. The second wave is the surgical management, in which we use a locking plate or a humerus nail. This is kept for fractures that are comminuted more than into 3 or 4 parts, or high demand individuals, younger individuals, or patients who have a higher demand. So the problem that we are facing, the primary problem is the varus collapse, which we wanted to correct. We wanted this head in a valgus kind of a orientation, but the difference in width of these two parts meant that we need some extra support here. So this was one of the big confusions. What should we use here to give this some support so that we can maintain this into a lateral kind of an angulation? So we decided to take a iliac crest graft, a big chunk of an iliac crest graft, and use it on the medial side for supporting it. Put the head into a valgus kind of a position and fix it with the humerus plate. And we used some extra cancellous graft on the fracture site to give it osteoinductive stimulus for healing. So this was what the immediate post-op X-ray looked like. This is the intraoperative image of the patient. This large bone is the iliac crest graft taken from the iliac crest of the patient. This is the humeral shaft. This is the fracture site. This is the humeral head, and this is the plate that we have used. So this is the head end of the patient. This is the hand end of the patient. So this was the final configuration, and everything was going good, but the patient was repetitively coming to the emergency of a hospital. He was admitted with an episode of hypocalcemia, and then later he came to the hospital with an episode of recurrent vomiting. The patient also had loss of appetite and nausea. The surgical wound was healthy, the surgical site was doing good, the range of motion was good, and had no problems. The main problem right now was the recurrent vomiting. The patient was vomiting around 10 to 12 times a day. And the first steps we did was we stopped tramadol. We started MSET. We did basic blood investigations. But patient was having no relief. He was still vomiting 6 to 7 times a day. Blood investigations again showed an elevated calcium, a normal PTH, a normal vitamin D, and an elevated ALP. The patient was now considered a PTH independent hypercalcemia. That was the provisional diagnosis that was made, and he was admitted under endocrinology department for further workup. So workup was being continued and a battery of tests were being done. So when we talk about hypercalcemia, the first thing that we are trained to think of is a malignancy, and I think so. He was being worked up for malignancy. The PTH profile was done, a peripheral smear was done, light chain assay was done for myeloma workup, DEXA was done, and still the diagnosis continued to be parathyroid independent hypercalcemia because almost nothing was conclusive of anything, none of the investigations. The patient also gave a history at this point of some swelling in his cheek area, which was of no significance to the patient, but taking that into account, we went for a USG neck and further to a PET scan. And the PET scan actually revealed a left-sided parotid lesion. So we were expecting to see something in the parathyroids maybe, but it came out to be something in the parotid gland. On further FNAC and excision biopsy, we saw features of pleomorphic adenoma. And the biopsy was also suggestive of a pleomorphic adenoma. The next few slides would be a pathology slides, which I would like to invite my colleague for that.
Good afternoon, everyone. So I'll discuss the pathology slides. So this is papinicular stains FNA smear of the patient from the parotid lesion, and we can see in this that there is abundant grayish green kind of metachromatic matrix material, which has a fibrillary quality and feathered kind of edges. In that, we can see some loosely dispersed cells which have a plasmacytoid kind of appearance. The nuclei are eccentrically placed, and cytoplasm is homogeneously bluish in then the nuclei are bland, the chromatin is evenly dispersed, no prominent nucleoli or mitotic figures are seen. So these are myoepithelial cells. Very occasional epithelial fragments were seen. So this is the MGG or May-Grunwald-Giemsa and stain smear of the same stain smear, which is displaying the metachromatic nature of the matrix. So this matrix is magenta colored, while the background cells are staining in a different color. So the cytology was quite characteristic of pleomorphic adenoma, and there was no other component, means a component in the smear which would suggest carcinoma X pleomorphic adenoma or any other differential diagnosis. An excision was performed after that, and in the excision histopathology, we can identify that this area is the normal parotid gland. The tumor is circumscribed, it has a fibrous capsule, pseudocapsule, and this lower portion is the tumor, which is again showing the matrix that we had seen on the FNA smear, which is of a myxoid or myxochondroid quality. And in that, we are seeing these kind of tumor cells which are arranged in cords as well as singly dispersed. On higher power, we can identify that these cells, which were seen in the FNA smear also in the background, these are the myoepithelial cells. And then there are few epithelial cells which are forming duct-like structures. So it is a biphasic tumor with no significant mitotic activity or necrosis or any other component. And the background is characteristic of a pleomorphic adenoma. On the request of the clinicians, because this patient was complaining of hypercalcemia, we performed a PTH antibody stain, immunohistochemical stain on the tumor. So this is the surrounding normal parotid, which is showing a predominantly negative staining, and this is the tumor, which is which is positive for showing cytoplasmic staining for PTH. The endothelial cells are spared, but the tumor is positive. But on retrospect, it is seen that PTH staining is also seen in normal parotid as well as in pleomorphic adenomas, which is unrelated to hypercalcemia that is seen in this patient. So this could also be non-specific. That was the final diagnosis rendered, pleomorphic adenoma. Dr. Puna will continue the process.
So it was pretty clear by now that he had a parotid gland tumor which was causing the hypercalcemia. So post tumor removal, everything was looking good. The calcium was normal, the phosphorus came to be normal, and even the radiographs, the surgery that we did, was showing signs of callus formations now, and the alignment was pretty good, and patient had a good range of motion. These are the photos that patient sent us from his house to showing his range of motion. So we were confused on a few questions with this case. First thing was, did hypercalcemia increase the tendency for non-union? So proximal humerus fractures are known for non-union as well as malunion, but did this case has a higher propensity to go into a non-union because of the hypercalcemia? Did the primary tumor and its paraneoplastic syndrome, probably the hypercalcemia, cause any dizziness or the TIA which the patient in the beginning was complaining of, which caused the accident? If we were not taking consistent help and review from the endocrinology department, probably we would have operated the patient, but we would have never treated the patient. From the pathology point of view, pleomorphic adenoma is not known to cause hypercalcemia. So was this a rare case? Was this the first case? Is another question. Fixation of non-union of proximal humerus fractures using a big tricortical iliac crest graft is not a very commonly used technique. So that is another thing that was special about this case. So this is one of the publications that I found, which is about that continuous infusion of PTH or PTH-RP can lead to hypercalcemia and bone resorption. So PTH-RP actually comes from malignant cells. So that can be a reason to cause bone resorption or hypercalcemia. So we have always read about hypercalcemia causing groans, bones, stones, moans, thrones, and psychic overtones. If we go back and look at the personal history of this patient, we can see some of those features here. The patient was having persistent loose motion, which was diagnosed as gluteal enteropathy. That was maybe his thrones. The patient had dizziness and fell from a scooter, which was maybe his psychic moans. Hypertension is maybe not related to the hypercalcemia. The patient was also having calcitonin spray, for which cause was unknown, which is the bones part, and he had mild renal failure, which can again be caused because of hypercalcemia. So the road to diagnosis was a long road. The patient was following up with us for a very long time, and he was consistently being undergoing a lot of tests. So from basic blood workup, we went to PTH profile, then we got a peripheral smear, then a serum light chain assay, then a DEXA scan, and then finally when we got a USG neck, we started to get a direction of where we are heading to. And the PET scan made us see the parotid gland lesion, and the FNAC and the biopsy were the final nails in the coffin. So without the appropriate and complete investigations, we would have never been able to clinch the diagnosis of this patient. We would have definitely treated his fracture. Maybe it would have not united if the hypercalcemia was not treated. So the lessons that we learned from this were we have to take assistance from the experts. We know things about the bone, but for everything related to the medical side, we need to refer to the specific department. So again, hypercalcemia and a pleomorphic adenoma. There are again publications saying that PTH-RP positivity has been seen, but not symptomatic hypercalcemia. So again, the question that is this one of the first cases remains. Proximal humerus fracture sequelae are known to be of four types. Ours was the third type, which is the non-union of the surgical neck. Our fracture had a very high risk of going into a AVN, as I told you in the beginning. So our fracture had a very short medial metaphyseal head extension. So the shorter the head extension, the less likely the head is perfused. So the fracture had a high risk of an AVN, and management of non-union proximal humerus fracture is not a very new thing. There have been techniques in the literature about managing these fractures. One of these techniques is where the surgeons have used a nail to manage the non-union. Uh, Another technique is this one, which in which the fibular strut has been used. It has been jagged into the proximal part, and then a Philo's locking plate has been used to stabilize this. Another very similar technique to ours by Dr. Maheshwari is he has again used a medial cortical graft, held it with two screws, and has shown good results. But in this technique, they have not used any cancellous graft at the fracture site, which was the basic difference in our technique. So we have fibula. Fibula is a very thin bone when it is not good enough to give a strong support on the medial side as thick as this tricortical was able to provide. Hence, the tricortical graft was considered a better option. It is a more thicker bone and it has more osteoconductive and inductive potential. It prevents varus collapse and provides stimulus for healing. An additional cancellous graft was our attempt to do everything at once and trying to achieve a guarantee for healing of this for this patient. The patient followed up 3 days back with us, 5 days back with us, almost on 29th to 30th of this month, last month. His all investigations look normal, and this is the last X-ray. This is the big chunk of bone that we have taken from his iliac crest, and this is the range of motion of this patient. So he can go up to 90° very easily. Now he uses his scapula a little. He can do active forward flexion. Then he has to use the other hand for some extra range of motion. But the patient is very satisfied. The patient is happy. So key takeaways from this for us were that we should always monitor calcium and vitamin D3 and PTH profiles in almost all our patients, especially those who come to us with non-unions or malunions or delayed unions. When in doubt, just take advice from the medical experts, because we at the end of the day are surgeons, and try to find newer solution to older problems related to our surgical field. That's it. Thank you.
Thank you, Dr. Polak. If there are any questions, we'll be happy to answer them. In the okay, can you go back? So this is the area. This is from where we had taken the bone graft. So this was positive on PET scan. We knew that this is our surgical site, so we ignored that. Sorry, sir. No, we don't do a PTH on all our patients. We just do calcium levels and alkaline phosphatase and phosphate. If then, yes, sir. Then we take help of our endocrinology colleagues. I think that should be better answered by the endocrinology colleagues. there any other questions?
This is on 30th, on 28th actually. Came to us. He's not on any medications right. Did we operate? He operated in October, and